Welcome all to Raaonline. So today we have a very interesting trial, the Select 2 trial. Okay, so this was published in NEJM, New England Journal of Medicine, in 2023. Okay, a pretty recent publication. Okay, so this is about a trial of endovascular thrombectomy for large ischemic strokes. Okay, the question is, if at all your patient comes within the acute window period and you do an perfusion imaging or CT and the infarct area is large, okay, can you do thrombectomy? That's always the question, because the previous trial, the diffuse trial, okay, which we have a separate presentation on it, they considered specifically only with the ischemic area less than 70 ml of volume. Okay, if it's more than 70 ml of brain volume, they actually excluded those patients, but they also form a bigger bulk. Okay, so people who come with an ischemic stroke with the involved segment of brain which is more than 70 ml, okay, they also form a bigger bulk of population, right? So can I do a thrombectomy for that group of people also is the question. Okay, so background is that randomized evidence-based trials regarding the endovascular thrombectomy telling about the efficiency and safety in patients with a large ischemic stroke based on the non-contrast CT and perfusion imaging is actually lacking. Okay, but these patients represent a significant subpopulation and may benefit from this endovascular thrombectomy. Now, the inclusion criteria is adults of 18 to 85 years of age with final diagnosis of acute ischemic stroke. CT angiogram or MR angiogram proven large artery occlusions, that is a distal ICA or MCA M1 locations, okay, and NIHSS more than or equal to 6. And the last known well to groin puncture should be within 24 hours, okay, and baseline modified Rankin scale of 0 to 1, okay. We'll see what is this modified Rankin scale in detail. It runs from 0 to 6, 6 is almost dead, and 0 is completely normal with physical independence, okay. So for this trial, the scale of 5 and 6 is actually clubbed, okay. So 0, 1, 2, 3, 4 and 5 and 6 clubbed. That's how this study goes. So these are some inclusion criteria. We do have specific neuroimaging inclusion criteria for this. We'll see that also later. So this is a gross inclusion criteria, and exclusion criteria is inability to undergo a CT angiogram or MR perfusion imaging, or there is a comorbid psychiatric or medical illness that would confound the neurological assessment. So those patients were excluded. Okay, to go for specific neuroimaging inclusion criteria, as I told you, it should be ICA, the distal ICA or MCA M1 occlusion only, okay, not M2 or M3, determined by the MR angiogram or the CT angiogram, okay, and non-contrast aspect score somewhere around 3 to 10, okay, as determined by the treating physician, very important, as determined by the treating physician, because it is not automated, okay. Sometimes when you take a CT, this aspect score comes as automated itself, but this specific trial, it is a duty of the physician to literally count and calculate the aspect score by himself. It is not an automated aspect score, okay. So otherwise, for your knowledge to tell, the definition of a better or favorable profile aspect score is if it's more than 6 or equal to 6. And 3 into 5 is called as unfavorable aspect score, okay. So in our trial, if I tell unfavorable aspect score, I'm meaning 3 to 5 of aspect score. And if I say it's a favorable profile, I'm meaning to say aspects of more than 6, okay. These are all just definition, okay. This is just definitions, okay. Aspect score of 0 to 2 are not included in this study, okay, due to expected poor outcome in these patients, okay. We'll see what is this aspect score also, okay. And the other definitions being the CT perfusion, if at all less than 30% of cerebral blood flow, that is, perfusion is very low. If such low perfusion is present in a very small area, less than 50 cc volume, if low perfusion is present in a very low volume of area, it is favorable profile. If low perfusion is present in larger area, then it is an unfavorable profile, okay. So these are all certain CTP inclusion criteria and definitions basically. So here we include only this segment. Okay, we include only this segment. We are taking only unfavorable profiles in this particular trial, okay. And similarly, MR perfusion imaging profiles like ADC, deficit coefficient is less than 620, okay, it's very poor coefficient. If it's very small volume involved, it's favorable profile. If more volume is involved, it is unfavorable profile, okay. So in our trial, we are taking only unfavorable profiles, meaning large and infarct size, okay.